I am Dr. Hisham Ahmed Nasr, Consultant Interventional Cardiology, National Heart Institute, Cairo, Egypt. This is my first video in the English version of my YouTube. We will talk about coronary catheters, Judkin-Wright. We will discuss Judkin-Wright catheter manipulations, femoral approach regarding catheter introduction, engagement, withdrawal, different scenarios, and design. Support will be discussed later. Regarding introduction, the course of the glide wire is always on the outer curvature of the ascending aorta. The ascending aorta axis is from the left posterior position to the right anterior position. So the wire ends in the right anterior located sinus, which is the right sinus. After passing the catheter over the wire, the secondary curve will lie on the outer curve of the aorta over the right sinus. The tip is directed to the right or non-coronary sinus. It never reaches the left sinus. LAO view is the typical view to see the coaxiality of the catheter to the RCA ostium. As seen in the lateral view, the tip is directed posteriorly and to the left, towards the right or non-coronary sinus, or in between. During introduction, whatever the direction of the tip, avoid contact with any calcified aortic valve leaflets. There is always a possibility of subclinical strokes. Catheter introduction over the wire may reach low or high in the sinus. Typically should be high in the sinus with a free tip. If low, the tip will not be free. A small dye puff may show opacification of the right cusp. Wire pulling, either gradual or sudden, there will be no jerky traumatic engagement in any coronary. Regarding catheter engagement, we will discuss how to engage and the mechanism of engagement. Regarding high approach, RCA engagement is just a balance between traction and rotation. And this will end with a safe, gentle, coaxial, and horizontal engagement of the RCA. Torque first with some sustained traction followed by stoppage of rotation. The catheter will continue rotation and ends with engagement of the RCA ostium. The clockwise rotation, if it is very gentle and short, wait for the catheter to engage the RCA. If the tip is stable, pressure is checked, followed by dye puff, then full injection. If the tip is deep, or if there is change in pressure wave, some reversal of rotation counterclockwise is needed to be more safe. Don't inject, even with no damping or ventricularization. The jet may induce spasm or plaque rupture. This segment with some angulation, especially if with superior orientation, is liable for spasm or trauma with a near powerful dye jet. Don't panic. No need for pulling the catheter. Just slow but sure reversal of rotation is enough. Avoid over-release of rotation for the tip to be stable. Typically, the end of the catheter before injection should be coaxial to the RCA. Also, avoid traction and or fast counterclockwise rotation to achieve a stable tip at the level of the RCA. If the tip is not stable, mostly due to breathing, especially with radial approach, some pushing may be needed. Rotation with no or insufficient back traction. This may cause downward displacement plus or minus reversal of rotation, which may reach the LV, especially if the rotation is at a lower level. Repeat again with some back traction and at a higher level. No or insufficient back traction plus or minus rapid rotation. This may cause downwards since no traction, displacement with a jerky since rapid rotation, traumatic RCA engagement, especially if the RCA is of downward orientation. Repeat again with some back traction. Rotation should be very gradual to avoid this jerky movement, which may cause deep engagement in the RCA and induce trauma or spasm. Sudden accidental entry in the RCA with the start of rotation may occur. If so, just gradual reversal of rotation is enough to be near the ostium. This is followed by checking pressure and injection. Extra traction of the catheter plus or minus extra rotation causes jerky displacement up in the aorta due to extra traction, with reversal of direction of the tip due to extra rotation. Regarding low approach, this approach may be used if small aortic root, small catheter size, or inferior oriented RCA origin. First, a small puff to see the level of the catheter to the right coronary cusp. Just making a loop on the right coronary cusp with some clockwise plus or minus anti-clockwise rotation to engage the RCA. The smaller the size of the catheter, the nearer it should be to the RCA. Or the other approach is to make a transient distal curve in the catheter by making a fast acute angle by pushing the catheter over the cusp, then rapid withdrawal of the catheter to preserve the angle, and clockwise rotation to engage the RCA. This is usually done if the catheter size is small, as in this case. Regarding the mechanism of catheter engagement, the tertiary curve is present in the Judkin right catheter, not in the Judkin left. It allows the catheter to rotate so that the tip would be directed to the RCA ostium. With proximal clockwise rotation, there is one-to-one transmission till the torque zone area at the tertiary curve, where there is some absorption and delay of transmission. Some more proximal rotation may end with a jerky tip rotation into the RCA. To overcome this jerky movement, the rotation of the catheter should be very gentle and wait or pause till the rotation is transmitted distally. The other option is to rotate over glide wire. Also, with this torque release, there is shifting of the shaft of the catheter from the outer to the inner curvature of the aorta. This shift will cause the tip to get a lower 1 to 2 centimeter, and tip will be directed to the RCA. To overcome or compensate for this shift, you should search for RCA at a higher level and or some traction proximally during rotation. Because of this shift to the smaller inner curve, the tip gets 1 to 2 centimeter lower level with tip elongation and tendency for downward direction. Notice the movement of the tertiary curve at the level of the aortic arch. Catheter shaft direction changes from anterior to posterior position, and the tip will be directed anterior as seen in the lateral view. Regarding catheter withdrawal, usually just pulling the catheter is safe, yet occasionally pulling the catheter may cause jerky deep tip introduction against the artery wall, which may be traumatic, especially seen if there is initial proximal upsloping of the RCA. The primary curve anchors on the upper border of the ostium, causing sudden dipping of the tip. Generally speaking, it is preferred the clockwise rotation during engagement should be reversed anti-clockwise before pulling the catheter. Before any anti-clockwise rotation, be sure that the catheter is in a horizontal level with the RCA. If it is in a higher level, there is tendency of upward traction of the catheter with rotation, causing suction of the RCA, especially if it is inferior oriented, causing trauma or spasm. Just pulling the catheter over the wire to prevent any jerky movement and maintain coaxial alignment is the safest procedure, especially with stiff tip wires. Or just pushing the wire if soft tip to disengage the catheter. Withdrawal in aorta should be over the glide wire If not, the catheter may be traumatic in relatively narrow common iliac artery or missed peripheral lesion. The primary curve is already wide, not a pre-packaged narrow angle. If the tip is not in the RCA with normal pressure wave, buffs are taken to check for the level and site of the catheter and manage accordingly. Normally, the RCA is on top of the coronary sinus of Valsalva, 1.5 centimeter above the right cusp. If convexity or straight line appears, it is too high. If so, don't push the catheter. It may end with a jerky engagement in RCA or aortic wall trauma causing some subclinical strokes. Just reverse the rotation and re-rotate at a lower level. If the non-selective puff is in the nest, it is too low. There will be no space for efficient rotation. So just pull back without any rotation, and after releasing any potential rotation previously done, there will be no jerky movement in the left coronary sinus or aorta. With the tip of the catheter directed to the operator and guided by few puffs. Usually more traction to get space up, not just compensation of the downward displacement as in high site catheter approach. More gentle rotation after reaching the level since there is relatively less space for rotation. Withdraw with the tip of the catheter directed to the operator. Why? For a free tip in this relatively narrow area. If withdrawn with the tip directed laterally after rotation, it will be eccentric in position nearly on the wall, with a sudden jerky upward displacement when withdrawn. As seen in this case. If low level with no space for rotation and with clockwise rotation of the catheter without traction, the tip has tendency to point downwards, especially if the primary curve is fixed on the aortic cusp with no downward displacement. This may cause deep, jerky RCA engagement, especially if it is inferiorly oriented. The other option is to change the approach to low approach as said earlier. After rotation, there may be tendency to engage the conus artery or paraosteal branches. If engaged in conus artery, there is no need to pull the catheter even after reversal of rotation. Just reverse the rotation gently, followed by a puff. If the RCA is seen or not, go at a lower level, gently, guided by puffs, and re-rotate to engage the RCA. A more clockwise rotation usually leads to a more deep engagement of the catheter in the conus artery. Conus artery always has a superior and anterior orientation to the RCA, may be separate or common origin or as an early branch. After rotation, there may be tendency to engage the conus artery first since it is more anterior than the RCA origin and superiorly oriented. Theoretically speaking, a more clockwise rotation, especially when the catheter is selective in conus artery, may allow RCA engagement, which is more posterior to the conus. This is not true, since, as said before, more rotation of the Judkin right catheter means more eccentricity with more engagement of the conus artery. RCA is usually inferiorly oriented in relation to the conus artery. So just counterclockwise and re-rotate at a lower level with some more gentle traction after some rotation to allow inferior orientation of the catheter tip, or change to a more inferior oriented catheter as Amplas right or even larger Judkin right. Consider short tip Judkin right, especially if common origin with RCA. If the conus artery is an early branch and the catheter is selective in the RCA, just some counterclockwise is enough to retain an anterior position with visualization of both the RCA and conus artery. If the catheter tip is a wandering tip, Buffs are taken to check for the level and site of RCA and managed accordingly. Consider the following. The origin of the RCA could be from the anterior surface of the right sinus. A selective injection of this variant is challenging. Since the secondary curve, which is lying on the outer curvature of the aorta, is with a short distance to the tip, the distal end of the catheter doesn't reach the middle of the aorta. It will be eccentric on the right side. With rotation, the shaft moves away from the outer curvature and the tip becomes more eccentric, with prolongation of the short tip with traction and rotation. This will allow it to reach the RCA origin if from the right side of the right sinus. If the origin is from the anterior surface of the sinus, there is a long distance to reach the RCA and less tip elongation since less rotation and traction. So change to longer neck catheter as M plus right or M plus left. Judkin right 4 will not help. REO view and or powerful injections may help to see the origin. A powerful non-selective injection towards the left coronal sinus may allow the appearance from the left side origin. Should be in LEO 30 to 35 degrees to decrease the overlap between both sinuses. Obviously, as said before, juncted right catheter will never reach the left coronary sinus. It may engage the anomalous origin only if it is in a horizontal oriented aorta when the left coronary sinus is at a higher level than the right, or from radial axis. So a non-selective injection may be helpful. Consider dilated aorta, especially with a powerful injection drawing its borders. At first, the aorta is vertical and dilated. With more dilatation, it is more transverse and RCA origin is inferiorly oriented. If the aorta is dilated, still vertical, just changing to a larger size catheter is enough. RCA may be inferior oriented origin from the start or with a transverse aorta with severe dilatation. A powerful injection in aorta may draw its borders. Notice the short distance from the origin to the right coronary cusp. Low approach techniques, as discussed before, will be helpful. Origin from the posterior sinus or above the sinotubular ridge is very rare. Judkin right catheter may reach the origin if above sinotubular ridge, yet M plus left catheter is preferred. Regarding the design, the shape of the catheter has primary curve, which is acute, secondary and tertiary curve, all in one dimension. The size of the catheter is according to the distance between the primary and secondary curve. With increase in size, there is increase in distance between the tip and the primary curve, with some tendency for a downward direction of the tip. Also, there is Judkin right ST short tip with shorter distance between the tip and the primary curve. This may help in paraosteal lesions or Shepherd's crook RCA. Judkin right modified, in which there is more acute angle of the primary and secondary curve. This may help in paraosteal Shepherd's crook RCA with superior orientation. The distance between the tip and the axis of the catheter in Judkin right catheter is shorter than that of the M plus left and comparable to that of M plus right catheter. Yet with M plus right, it is less eccentric after rotation. And this is the end of the video. Thank you for your attention and waiting for your feedback.